So welcome back, and as has been said, we have a full agenda, so I'm going to stop talking and open up the mic to the others that we're going to hear from today. The first session this morning is on promising initiatives in the North, and we've got 4 different presentations. So I'm going to ask now that our presenters from the Saskatchewan Northern Intertribal Health Authority, is it NITA or NITHA when you say that? Yeah. TB high incidence strategy, promising findings and lesson learned. We have Nambi Nambuka who's going to present today. So welcome.
Good morning, everyone, and thank you for the kind introduction this morning. My name is Namdi Ndobuka. I'm the Medical Health Officer with the Northern Intertribal Health Authority out of Prince Albert, Saskatchewan, and I'm so pleased to be here today to share some of our findings with our high incidence strategy evaluation. So I'd just like to start by acknowledging that the land upon which we're gathered this morning is Treaty 1 territory, the ancestral homeland of the Métis Nations. So just by way of objectives, I'll be highlighting the strategy itself, what it entails, and the different components. Sorry. Next slide, please. Yeah. So I'll be touching on the high incidence strategy, trying to give a little bit of a description, and also describe the role of NITHA in the strategy, what we, to what level we participate. And I will then lastly share some of the high-level findings for our strategy evaluation. Next slide, please. So this slide shows the communities that we provide services to. That's 33 First Nations on-reserve community in northern Saskatchewan. We consist of 4 main partners within the NITA partnership. And our population is approximately 35,000 people as of end of 2015, based on the INAC data. And that consists of 47.5% of the Saskatchewan on-reserve population. And when you add the maths, it gives you about 3% of the provincial population. So quite a good number of population that we cover and provide both nursing and public health services to. Next slide. So just to give you a sense of the burden of disease within that population, the orange line there shows the incidence of TB in NITHA, and the purple is in Saskatchewan, and the gray line is the Canadian incidence rate. So you could see right off the bat that we are really dealing with something huge in the northern communities that mainly consist of First Nations. And as you heard yesterday from my colleagues from the TB Prevention and Control, we are presenting the North bears the greater burden by more than 47% of the cases of active TB reported in the province. Thanks. So here, just to give you some bit of context to our program, I mean, needless to talk about some of the key issues that impact TB within our province here and elsewhere, particularly talking about housing and other social issues. It was interesting yesterday, one of the comments that was passed on, which really resonated with me. When someone said that TB is a social disease with a medical connotation. So I think looking at that, we really need to look beyond the disease itself and think of some of those ways where we could address other social determinants as it relates to the disease. So historically, there are some communities that have continued to bear the burden of disease for quite a number of years in northern Saskatchewan, over 20 years precisely, and the rates are as high as 200 cases per 1,000 population in those communities. And the province actually stepped up to the plate to see what could we do beyond and above the provincial strategy to do business differently in these communities to address the high burden of disease. And that was when the conversation around a high incidence strategic approach was developed. So indeed, the high incidence strategy is a multifaceted approach, community specific, that really deals with the issue as the community deems appropriate. So it's tailor-made for the community, and it's not a one-size-fits-all approach. And most importantly, this strategy has resource implications in terms of additional mobile clinics, additional staffing, provision of incentives to ensure that clients enhance their adherence level. So the province also, in collaboration with our funders, FINIP, also did due diligence in terms of providing the necessary support financially to move forward with the project. At that time, we didn't really have any particular approach to identifying the high incidence communities. But when the group came together, we decided to articulate some of the criteria which we think worked best at that time, even though now we don't have the Health Canada definition for high incidence strategy. So this slide shows some of the criteria that we did utilize to come up with those communities that were designated as such. So we looked at the size of the community. We also looked at the annual incidence rate in those communities. We looked at the persistence of those incidents beyond 100,000 cases, 100 cases per 1,000 population. And we also looked at the prevalence of HIV within those communities. And lastly, but not the least, we looked at the historic or the presence evidence of TB drug resistance. So we applied this criteria across those communities in northern Saskatchewan and also weighted them. We had different scores that we assigned and classified them into highest priority communities, high priority, and modest priority. So we then identified 6 communities, 2 were off reserve, and 4 were on reserve communities that were categorized as highest priority that we should be deploying this customized strategy to. So this slide shows the summary of all the aspects of the strategy. All are very important, but from our perspective, we really threw most of our weight behind the community engagement because we felt that that is where some of the strategies should be coming from. We did our best to compose a team in each of those communities that consisted of frontline workers, that consisted of health portfolio counselors, community leaders, and also our team from NITA providing that third-level support. We also, threw our weight behind early case detection, rapid deployment of contact tracing investigation very promptly upon when it is called. We also ensured that we become proactive in collecting sputum from clients that are at risk and have been involved in the contact trace to ensure that we decrease the time from the time of exposure to the time of diagnosis. We also drew a lot of attention to the LTBI management. Our goal was to expand the pool. Our goal was to make sure that we increase screening and put more people on prophylaxis. And last but not the least, the social determinants, which of course we've been highlighting here yesterday, which were the root causes of some of the things that we see. And believe you me, of all the gains that TV program have made over the past couple of years, housing and social determinants are the biggest setbacks that we've had that impacted negatively on those investments. So the objectives of the strategy, as we had yesterday, was to decrease the incidence rate by 25%, and of course, increase knowledge amongst the community members, and then expand the pool of our LTBI infection. So the TB program in Saskatchewan consists of several key stakeholders that work together in a very concise and collaborative manner to ensure that success is ensured with the clients in the middle of the whole scenario. So we really take that client-centered approach to deal with TB, so that a wide variety of stakeholders which commits their time and resources to ensure that the high incidence strategy continues to be a success. So we have the TB prevention and control, the communities themselves, which are very key in terms of taking the leadership and ownership of those strategies. Our funders, the First Nation Inuit Health Branch, of course, the Saskatoon Tribal Council, the then regional health authorities, which now rolled up into Saskatchewan Health Authority, and of course the Ministry of Health, and the primary health care colleagues, and of course the patients themselves. So we all work collaboratively to ensure that this high-stress strategy continues to gain momentum. With regards to the role that we as an organization continues to play in deploying and ensuring that the successes of the high-stress strategy continues to fly, is, we provide the overall coordination for each of those communities. Like I said earlier, we developed community-specific outbreak management teams for each of those communities, and we continue to provide an opportunity for them to meet on fairly regular basis, to troubleshoot, and then to ask those questions and provide support as we deem appropriate. And we continue to ensure that we, raise our voices at different tables as it relates to advocating for improved social determinants, as it relates to Indigenous health. And we provide nursing support, so we provide training for the TB workers and the nurses with regards to DOT and other professional development that will make them to continue to maintain competence in the job that they do. And we have direct presence in the communities to facilitate contact investigation. We don't just leave it for the frontline staff themselves, but we also give them very good support to ensure that they are done timely and ensure that results are back and the individuals get on treatment or prophylaxis, as the case might be. We also participate in case management, particularly for individuals that are having, difficulty in maintaining their treatment regimen or defaulting from treatment. So we host case conferences with the ID physicians and sometimes with the patients themselves to ensure that they are aware of their own role and responsibility as it relates to their care. So we also provide incentives and by way of enablers to enhance adherence. So that's the key component of our strategy, which we have, which we are continuing to take very seriously. We also develop educational materials that is really tailored to each of the communities. For example, we do newsletters, we do YouTube videos that are showcasing individuals from those communities and having lived the experience. And from our feedback from the strategy evaluation, those materials were received very well because individuals tend to accept materials that they were part of in terms of the developing, and also seeing individuals that are from their own community participating in some of those video projects really was a welcomed idea. So we took a shot at evaluating our work after 3 years of initiating the project since 2013 up to 2016. So we received funding again from FINIP, and thanks to our funders to making this work very successful, and also support from PHAC by deploying a public health officer who helped to move forward with this evaluation. So with this evaluation occurred in 2017, we decided to take 3 out of the 4 high incidence communities in NITHA for obvious reasons, and our key questions were to know whether the TB high incidence strategy was reducing the incidence in those communities. And secondly was to see if at all our initiatives, particularly around increasing community education, was actually making any impact. And last but not the least, to know whether they're actually participating in timely recognition of the disease and presenting for treatment. So we did apply a mixed methodology, both qualitative and quantitative approach, to come up with some of our data. We did rapid, limited chat reviews. We also interviewed stakeholders across all the continuum of stakeholders that I did highlighted earlier in the slides. So we also surveyed community members, including those with lived experience, latent TB infection, and those that had active disease that were treated between those periods of the evaluation. And we also interviewed just any community member to see if they came across some of the educational materials and some of the campaign awareness initiatives that we deployed in those communities. So we also reviewed the database that was hosted at NITHA and also TB prevention and control. So those were the sources of our data. So these results that I'm going to share are not exhaustive, it's just a highlight. The final report will be shared with our funders, and it's been shared with our communities already. So we are at the final stages of fine-tuning the necessary approvals before we could make the results available in total. So with regards to the LTBI management, our goal was to increase the screening level and also the number of people that are being prophylaxed. So here, for the 3 communities that we evaluated, we looked at the period before the evaluation and after the evaluation period. So what you will see, sorry, trying to point here. Oh. Okay, I'm trying to point to my red flag. It's not going. Did you want to go back? Yes, please. All right. Okay, so before the strategy, 2009 to 2012, for Community A, there were only 36 individuals that were offered prophylaxis, and for the second community, it was just 31 and 16 for community number C. But when you look at the period after deployment of the strategy, you'll see that we had some good increase in number of LTBI cases that were offered treatment, except for the third community where we didn't really have much cases after the deployment of the strategy. So that's why we saw quite a small number of difference between the pre and the post strategy deployment in terms of number of individuals treated for LTBI infection. So here we also looked at the, the location of the mobile clinics and the ability of individuals to attend those clinics. What we saw was that there was some kind of correlation between the location of the mobile clinic and the attendance. So here you will see that if the mobile clinics were located in Prince Albert, we tend to have more people attending, versus when you have the clinics in communities like Stony Rapids. And one thing that we thought might have been responsible for this higher increase in attendance when the clinics were hosted in Prince Albert is that clients have the opportunity to come to the city and get groceries and at the same time meet their TB appointments. But in other communities where there might not be anything for the clients to do, rather than wait for long hours to see a physician and then get back to their communities, they tend to shy away a little bit from honoring those appointments. So what we are thinking is that in going forward, there's a way that we could change some of those model of the mobile clinics and to bring services as close to home as possible. That will definitely improve the attendance rates. So for the respondents' preference to the mobile clinics, what we saw here was that about 54% of the respondents actually preferred that the TB clinic be hosted in their own community where possible. So one of the goals of the strategy was, early case detection. So we made effort to ensure that we actually get clients early before they convert to smear positive. So what we saw here, if you look at the blue bars for each of those 3 communities, smear positive, the middle one there, that's showing that before the strategy and after the strategy, which is the orange bars. For the smear positive, there were more smear positive cases before when you compare that to after the deployment of the strategy for the first and the second community, but that wasn't the case for the third community. And again, I believe it might be because of those fewer cases that were reported after the strategy. So overall, we believe that we've made a significant stride here in terms of getting people early, early diagnosis before they convert to smear positive and become more infectious. So here, this slide shows the overall incidence for those 3 communities, and you could see that there, where you see the red line, that was the point when the strategy was deployed, And going forward, we experienced quite a good number of decrease in cases, and overall, we saw about 76% decrease in cases for one of the communities, that's Community C, and overall, we had 41% decrease in active cases for that period of deployment. So we tried to gauge the community members' knowledge of TB, both active TB and latent TB infection. So what was striking is that of all the questions that were posed, particularly around active disease, there was a good understanding of what active TB meant. However, there was very little understanding about latent TB infection and what it actually meant. So that's what this slide is actually showcasing. So we also try to look at the risk factors. What are the things that actually put people at risk for contracting TB in those 3 communities? And most importantly was being a contact to a case. And for the last community there, Community C, it was more of alcohol, substance abuse being the risk factor. So this really has some implications in terms of, how we could do business differently, where we should be focusing in terms of, moving towards identifying some of those risk factors and seeing what we could do differently in those areas. So we did come up with key recommendations. I'm not going to read all of them in the interest of time, but here I would like to speak mainly to the second point, which is about adopting trauma-informed practices. I think there is a need for us to continue to make concerted efforts to educate some of the healthcare providers to understand some of the negative impacts that the legacies of Indian residential schools and Indian hospital, which we saw yesterday, is having on the community members, particularly as it relates to them attending clinics and seeking care when the need arises. We also felt that if we have a digital portable device that could enable clients, get X-ray instead of traveling long distances and then, taking more time from exposure to treatment, that will really be a game changer for our program. We believe also that community engagement will be key in terms of continuing to engage those leadership on an ongoing basis, and again, addressing stigma around TB. Some of the communities still have a lot of stigma associated with it for obvious reasons. Education and awareness, we believe that if we focus our attention on the youth by developing some kind of TB curriculum that will be taught in those schools, then we might be making a good investment at those points. And through the kids, we can also reach the families who might become aware of what TB is and how best they can also support the TB program within their various communities. Then in terms of leadership engagement and communication, we believe that the leadership, the chief and council, will play a key role in being the ambassadors of the TB program within their various communities. So we hope that our engagement will be more regular and more strategic. And as a matter of fact, we're thinking that once a year engagement will be ideal for those stakeholders. So to conclude, the multifaceted strategies are implemented in northern Saskatchewan communities, designated as high incidence strategies. Since 2013, TB rates have decreased in all the 3 communities, and we've reached our target of 25% in 2 of the 3 communities. Treatment of LTBI infections have been expanded to almost about 70%. And gaps still exist in the current TB program, and we're thinking that changing the model, which we are actually working on right now in conjunction with the TB prevention and control and the province, will really make a difference. And the high incidence strategy community members had adequate knowledge about TB, but not the latent TB infection. So with that, I would like to acknowledge some of my colleagues in the program that helped to undertake this work, and also Shadi, the public health officer that worked on the project, and of course, TB prevention and control, and our funders, FINIP. Thank you for listening.
Good morning. My name is Gilbert Benjamin. I'm from Buffalo River Dene Nation in Dillon, Saskatchewan, part of Meadow Lake Tribal Council, one of the 9 First Nations at Meadow Lake Tribal Council. Good morning to everybody. Thank you for the invitation to the Treaty 1 First Nations and Métis territory. Thank you to the organizers. But before I start, I'd like to take a special mention to one of our neighboring communities from La Loche. I'd like to ask Leona and Rita to stand up. They're still dealing with the issues that happened the last 2 years, so we'd just like to honor them. Merci. Thank you, Dr. Debuka. When we heard first, were informed about the second highest TB rate in northern Saskatchewan, we had to act immediately, and we had to do it fast. Initially, at the beginning, we had team members of 3 CHNs, 2 CHRs, and myself, along with a TB control. Now we have a TB worker in a community. We engage in the community through local radio station, newsletters, our web page, posters, door-to-door campaign, and a very important one was the political engagement because of the housing issues in our community, the O&M infrastructure issues in the community. Since then, we had 12 houses built and 12 families moved into a new building. We have an ongoing project of a water treatment plant that's began in April and will finish sometimes this year in July. So it's very important to get the leadership involved with the community health. The intervention with the community was positive. Community cooperated with the TB clinics. Once clients were diagnosed with positive TB infection, they were notified. The majority of the clients cooperated with the treatment program. Although we had some challenges, there was a few challenges, difficult clients cooperating with the program and the TB worker. Challenges as scheduling appointment, missed appointment, stigma of TB, amount of medication taken, time frame of treatment, transients, community to community. Number one issue was the mental wellness issues. People from residential school, drug addictions, overcrowding, sexual abuse, physical abuse, and to add on this health issue of TB was another challenge for them. They felt like the expectation of the team was too high. So we need to be very careful of how we deal with the clients. In order to deal with these clients, we have to have good communication skills, life skills, and counseling skills. When a TB worker comes to me about a certain client that she's having issues with, I would make an initiative to have a one-on-one counseling with a TB client. And at the end of the day, it's their health, and we're just there to support them to go through the process. And the successes are good communication skills, dedication of the team, public awareness. Our theme was in Dene called TB Beneruhni, meaning understand TB or know what is TB. Thank you to the TB Control, NITHA, World Health Organization, Health Canada, especially to the dedicated health staff in Buffalo River. In closing, we can cure and eliminate TB with good interaction with clients, staff members, and especially the NITHA team helping us. Thank you very much.